So I was going to talk to you guys, kind of put a little bit of it together, because we had Pat talk about pediatric, Emmy talk about some of the suicide prevention models, and just how you guys can like granularly take this to the bedside. And so I think some of the points that Emmy's mentioned, and also Pat, really help you sort of how to risk stratify when you're sitting next to a patient and how to actually counsel them. So you know, some of the work that's been done shows that even though we think it's important, and some of the surveys we sent out there, I'll look to see what y'all's responses were specifically, but a lot of the survey we sent out, people do feel like this should be something we should be doing. But even though we think it should be happening, a minority of providers are actually doing the counseling. There's a lot of reasons for maybe why this is the case. Some folks think that, you know, is it legally allowed? Absolutely, yes. There are no state or federal laws that prohibit healthcare providers from discussing firearm safety with their patients. So also another thing people aren't sure about, and just like Emmy had mentioned, should we be screening everybody? No, not necessarily. You know, I think it's something we don't have, like the cart before the horse is definitely an argument here. We're not really sure that screening everybody is going to make any impact down the road in terms of how people store or death or injury prevention. So right now we say just high risk both seems to be the most logical way to go. And then knowledge gaps. A lot of providers don't feel comfortable. They may be, you know, anti-gun, or they may have never touched a gun, or maybe they just don't think there's a place for it in the healthcare setting. But there's a lot of knowledge gaps onto why people don't feel comfortable screening in the healthcare setting. So I wanted to talk about that with you all. So the 2015 National Firearm Survey, which I think a couple of our collaborators at the table have been a part of, was a web-based survey, about 4,000 responses. People sitting in their homes just filling out a survey about whether or not they think it's okay for doctors to ask about guns. And so at least it's sometimes appropriate, and 2/3 of non-gun owners and about half of gun owners think it's appropriate. So at Emory, we wanted to do an extension of this and sort of look at it a little bit more, you know, a little bit more specific to the healthcare setting. So we had our EMORY and our GRADY firearm survey, which was modeled heavily off of theirs, but also had a couple of other clinical situation preferences, like demented elderly, suicidal, intimate partner violence, and we also, similar to them, linked to perspectives and access. So through this, it was about 200 branching logic questions, kind of similar to the survey you guys just looked at, a little bit of those kinds of questions, some personal questions, some demographics, access and perspectives. So we had, it's a self-administered iPad. GRADY, Emory Midtown, and Emory Maine had it, and then we're also going to try to extend to rural because we think that's a really important population. So understanding your patients is critical for you to, you know, we're Georgia, we're a very different gun-owning community than Colorado or up in Rhode Island. It's a very different sort of environment down where we are, and so we really wanted to look at that and be able to tailor our understandings, our risk scenarios, and our interventions based on our population. So we found in our county hospital about 64% were our respondents, about 19% were the academic site, and the blended site were about 17%. About 26% have access to at least one gun, and the mean access for those who do have them are about almost 5 guns a person. We had most respondents were female, age about 45, and then mostly Black and African American participants. About 34% were have a child in the home, a couple of veterans in there, and then as you can see, kind of politically all over the place, like liberal, moderate, and conservative. So we did have a kind of a good mix of patients in terms of political backgrounds. So so far for our prelim data, we have about, you know, a good assortment of gun owners and non-gun owners who are in support of being asked in lots of variety of clinical settings. So personal mental health issues, gun owners are actually very supportive in our population, domestic violence as well, and then personal cognitive issues and family cognitive issues, gun owners are also pretty comfortable with providers asking. So, you know, kind of this take home is just to say, like, it's nuanced, but people are supportive, and especially in this population, reflecting that in addition to the National Firearm Survey, we're seeing that in our Georgia population as well, which arguably is a much more politically conservative, a different sort of environment, and folks that in the actual ED, like we're sitting there and they're in pain in the emergency department answering this question this way. So who should you be screening? This is an important question because a lot of times you can tailor it out to pediatric unintentional, suicide prevention, demented elderly, but putting it all together is a little bit difficult, and knowing who are the high-risk people is something I hope you can take away from this talk. So who should you screen? And the What You Can Do initiative, which you'll hear a lot about tomorrow at the plenary session, or the main talk tomorrow. You'll hear Garen when you talk about the What You Can Do to Stop Firearm initiative at UC Davis. They're taking together some of those statistics we have, as well as just some of the literature out there, and trying to put together a holistic sort of look on who's the high-risk group to screen. So we've defined, and people are emerging in this way, defining acute risk of violence to self or others, so suicidal patients, and folks who are violent towards others and youth unintentional. Folks who have individual risk factors, which I'll go over in a minute, and members of demographic groups that are high risk. So those are folks, these sorts of flavors of people you should think about screening in your emergency department. So like we talked about, pretty obvious, you're depressed, and suicide is a huge burden. So people, if you take away nothing else, the depressed and the suicidal patients are folks you should think about routinely screening. And then also folks who are at harm to others. So perpetrators of violence are people you should think about screening. Folks who have individual risk factors to think about, like we talked about, violent victimization and perpetration, intimate partner violence, alcohol and drug abuse, and those that have poorly controlled or serious mental health issues. And for those of you who work with elder populations, it's an unfound, or one that's not really thought of frequently, but your demented elderly folks, or folks that are suffering from dementia, or folks, they have guns too, so it's important to think about screening in those situations as well. And then for demographic groups, these are what, those wonderful slides that Megan had shown, the ones that are acutely high risk. So children and teens for unintentional, middle-aged and elderly men, especially white men, for suicide, and teen and young men for homicide. So sort of if you think about just all of those groups together, that you should get your antenna up about thinking about screening for firearm safety in those populations. So now that you've thought about who to screen, how are you going to screen, and what's the approach and the strategy you should use going forward to talk to patients? So today is a big portion, building your own self-knowledge, and self-knowledge in Georgia is going to be different in your communities as well, because being aware of your community resources, your local gun ranges, your local laws, like that's very important. And so we argue that as being an important part of understanding. And then a lot of the data we have has been showing basic interventions with you store your guns and your ammo locked, stored separately, and that is like the basic minimum. But we found that probably a tailored approach is much more appropriate. So looking at the patient in front of you, balancing their risks with a tailored intervention to store more appropriately is something we're looking at. Then also look for resources and follow-up plans. So as emergency providers, it's a little difficult. You can enact that gun safety care plan with hopes that either you follow up, a researcher follows up, or the primary care doctor. Like I think connecting to them a person and saying, hey, I've got this plan I've initiated for this patient. Can you follow up and make sure we're storing more safely? Again, it's patient-centered, it's respectful. A lot of us, just like Emmy had mentioned, are something where we may have our own biases, just like in a lot of different healthcare scenarios, like we don't bring that to the patient. Those are gun owners who are high risk for a specific reason, and you make sure that you talk to them respectfully. And then also dialoguing with them. A lot of times you want to have this, I wish I could just give you this one line that's going to fix it, here, do this, and it's going to fix the problem. But it's actually a lot more nuanced. So being able to sit with that patient and have a conversation with them and build upon that doctor-patient relationship really will be something that's more effective. So, and again, we kind of think of it as like Goldilocks. You don't want too much, you don't want too little, you want just right for that patient. So starting the conversation, okay, so there's certain reasons you thought about screening them in the first place, right? So why are they high risk? Is it because of depression or suicide? Then you can think about entering, so say it was suicide. You say, oh, hey, I see that you're really high risk right now. You just lost your job. Your wife left you, you've got a trouble with alcohol. Given that, I understand that I want to ask you a couple more questions if that'd be okay. And then just ask them, do you have access to guns at home? And sort of enter it that way. So you frame it within their risk context, right? So also with pediatric unintentional, seems to be a lot more palatable to people. It's keeping their kids safe. So You know, playdate safety is sometimes what a lot of pediatric providers are focusing on. So you ask other parents if there's guns in the home where your child plays, and then also you can talk about how people ask other doctors, other patients about families about their gun safety. Intimate partner violence, that's a little bit harder. Sometimes we do a lot of victim-centered and perpetration-centered. So I think most of this is focused on when you're speaking to victims. So you'd say, hey, can we talk about how to keep you and your family safe? Or, hey, you're like Megan had mentioned, you're very, very high risk. I see that you're being abused by your partner. Do you guys happen to have guns at home? You know, and so being able to kind of frame it in their context of their risk scenario is really important. And then arguably, I think exploring their reasons for why they own is important as well. You can't really counsel them effectively if you don't really know why they own in the first place. So if it's, I own for hunting purposes, I own for a hobby, it's my constitutional right, you know, whatever that reason is, it helps you understand how to effectively counsel them, because then you know, okay, how am I going to be able to help this person store if they own for personal protection? That's always a harder reason when people have this notion that it's their safety and they need to keep themselves safe. So yeah, you need to explore that, and that'll help you have your nuanced, tailored risk discussion. So for our GRADY patients, we're seeing that most people own handguns for protecting against strangers. So you can see it's a little bit different than your hunting, collection hobby. And then we had an interesting other category. We tried to we tried to collect data about folks who, even like criminal activity, we're trying to get that too. So anyway, but this is the reason people own handguns. For long guns, it's a little bit different. So folks own for, hunting is another big reason for owning the long guns. And then they have protect against strangers is also a pretty high reason. So again, once you know why they own, you can tailor this risk-benefit discussion with them. So you look at all the risks. So unintentional injury, homicide, suicide. Hey, you're really high risk right now. That doesn't mean you're high risk in 2 months, 3 months. But right now I can see you're in a pretty high risk scenario. And then even though I know you want peace of mind, you're worried, you want to go sporting, self-defense, those kinds of things seem to be not as high risk right now as compared to your acute risk to yourself or harming someone else. So being able to sort of nuance that in their mind to help shift the perspective is important. Then this is kind of like what Emmy and everybody said on slide form. So being able to sort of tailor this in a discussion, and one of our collaborators helped me make this Arms with Ethics person. So she said she helps counsel suicidal veterans, and she even went to the point where you can take it out of the house all the way down to locked guns, ambos, locked and stored separately. So those are the two sort of most to least is what we recommend offering. But you can even nuance it to the point where I'll never forget the way Casey mentioned she counsels a suicidal veteran, and the way he keeps himself safe, because gun ownership is such a core part of who he is, that he feels naked without his guns, that he can't not have them, even though he does acknowledge he has drug abuse issues and alcohol abuse. So he would line the inside of his safe with pictures of his family members, and so he wouldn't. He's like, okay, every time I go in there, I know my family loves me. It's just one other added layer, nuanced variable that helps that specific patient not complete a suicide. So again, you can kind of take it even to that extreme, but what we usually say is when they're the most risk, firearms out of the house if you can. And so those were all the things that Emmy mentioned, and I'll talk about where that can go. And then also, you could have them locked in-house with the at-risk person without access. So give that a family member or a trusted person have the key or the combination. And then the least is in the house, but and unloaded, stored with locking devices, and then also the ammo stored separately and locked. So that's kind of the baseline, is them locked, stored separately. And then again, you remember they're high risk for a reason. Mitigate why they're high risk. So if they're depressed, treat their depression. If they have alcohol abuse issues, go ahead and get them into substance abuse and counseling and all that. So make sure that you're addressing the reason they're high risk, so that eventually they can, own again and it be safe for them. So options out of the home, and this is kind of based on some of Emmy's work where she does the Lock to Live campaign. It's a wonderful thing. I think she just mentioned the tools coming out today, so you guys will be able to review this. But you can store with a family, friend, neighbor, gun shop, shooting ranges. You can do one of these commercial storage facilities like these you see here, pawn shops and police and sheriffs. And so you know that there's background checks, know your state laws. And then in-home options, and this is something Jeremy will talk about a little bit. So you can disassemble. There's all kinds of ways. When some of the firearms, some of the handguns specifically, you take apart, it's just inconceivable that a drunk person would be able to put that together. So that could help. You know, you could lock boxes, safes, and you can also do a combination of all those things: disassembled, cable lock, trigger lock, in a combo storage safe. So there's a lot of options to be able to kind of further layer that within the home. Sometimes and we've found with some of the patients we talk to, there's some folks who are just very reluctant to talk to you about this, and you may have that in your interactions clinically. And again, if you just back up again and always make sure you say, you reinforce that your safety is the most important thing to me, and I care about you and your family, and I'm your doctor, and I want to help you. And so kind of backing it up and just saying that I'm trying to put this in the context of safety and injury prevention. Their answers are confidential unless they're imminent risk, which, you know, the folks who say they're going to harm themselves, you know, with a gun, and they're going to do it right now, like that's maybe a different group. And then also try to maintain that non-judgmental, doctorly, professional thing you guys always do. I don't think we bring a lot of our own biases usually to the exam table, so I think being able to back up and make sure we keep a non-judgmental professional tone is important. So I wanted to have some resources for you guys, so we'll send these out to you eventually. These are for the patients. So, and again, the What You Can Do initiative has some really great handouts. So if you go on their website, there's some really great resources for them. And then for you, so there's a lot of wonderful online courses. So the CALM, Counseling on Access to Lethal Means, is a free online course you can take for suicide prevention. Some of the strategies you use in the CALM training is applicable to multiple settings. Also the AMA, which I think almost all of y'all were on, just put out a really great kind of general approach to firearm safety and storage. That was wonderful. Like I said, What You Can Do has some great handouts for you and for patients. There's also a Coursera course that came out yesterday, I think, from Johns Hopkins that has a wonderful kind of more in-depth semester-like class type thing you can take. So if you guys want to look at that, yeah, so it might help. I didn't know if it would help with that. If you want to send that. Yeah, because especially for you all, I think some folks who came to this workshop hoping to get some of that policy work, that it might be something that would be of interest to you. Because again, like we mentioned, most of my interest is like having that bedside discussion with patients and how we can do that effectively and safely. But yes, policy is important, and so making sure we have resources for you to be educated in that way is good as well. Also, Jeremy's going to talk mostly about this, but being able to kind of have those discussions and not sound dumb is important, and being able to just have some basic understanding of guns, what different kinds there are, different ammos, different storage containers, and even firing a gun, if you're interested, might help you when you're having these discussions. Because most of the people you're counseling, let's face it, they're gun owners, and they have a lot of knowledge, and most of them respect, want to be safe and smart gun owners, and they want to have someone who's counseling them that has some credibility. So I think being able to kind of build your own knowledge is helpful. So there's some NRI courses. Those are kind of the Quick Shot range in Atlanta is the one that we use, the Norcross gun range, and then also we have some sessions. So we'll have one for you guys today. And so curriculum building is another thing I wanted to mention briefly. So we give lectures not just to our emergency medicine crew, but family medicine, internal medicine, psych, OB, peds, try to make it sort of because when I put that in my tailored gun safety plan, I want to make sure the next doctor that sees them understands what I'm talking about, and so help to kind of build that as a full medical profession. So not just emergency medicine. We want arguably our family medicine, internal medicine doctors should be very, very good at these conversations as well. So we do lectures for them. We also are trying to do the follow-up protocols, like we mentioned, like I initiated this care plan, so can you follow up and make sure that they made a safe change or helped address the next step in their care. And then also you want to take sort of a unified, like we mentioned, stakeholder approach, like us as physicians. It is our lane, and so let's have all of our physicians make sure we're on the same page with how we have these discussions. And then hands-on training has been relatively controversial in our department, but it is something I think has been very beneficial for our providers, especially those that are anti-gun technically and don't feel comfortable handling or even knowing anything about guns, but they still want to have safety conversations with patients. So we do a range-based session in Atlanta, and similar to how some of the other partners have as well. We have this is Sergeant Spivey, who's our range master down here, teaching one of our residents how to shoot, and then Captain Shelton is the guy up at the top, who's one of the SWAT team members and works really closely with Jeremy. So I'll have him talk a little bit more about those. But with that, any questions about bedside discussions right now?